No.
Yes,
sir. Started.
Yeah, fine. So shall we go ahead, sir?
Yeah,
Krupa, sir?
sure.
Yes.
Yeah. Go ahead, please.
Yeah, fine. Good morning, everyone. I welcome you on behalf of ISA Tamil Nadu. After a gap of 1 month, we have been continuing this online program every month, every third Sunday from 11 to 1 p.m., where we give the opportunity for the city branch to present a speaker and of their choice and the topic of their choice. As well as we have two renowned, very prominent moderators and another speaker, which will be arranged by ISA Tamil Nadu. And this program, online program, we have been continuing for the past 18 months. And this is our 19th program. And we also get the credit, Tamil Nadu Medical Council credit us. This short introduction. I thank you all for joining the online program, despite all waiting for the final cricket that's going to happen today. So I take this opportunity also to wish a good luck and success for the Indian team. So this is a short introduction. I would like to hand over the mic to Dr. Gomati. Madam. Gomati,
Good morning
madam.
to all. Good morning to all. First of all, I like to thank TN Office Bearer for giving our city branch an opportunity to host today's webinar. I take immense pleasure for inviting, for the National Office Bearers and Tamil Nadu ISA President Dr. Selvakumar sir, President-elect Dr. Krubakaran sir, and Secretary Dr. Bhaskar sir, and Treasurer Dr. Giridharan, Academic Chairman Dr. Amudarani ma'am, and Chief Election Officer Dr. Kumar sir. I also extend my warm welcome to today's moderator and chairperson, Dr. P.S.N. Raju, who is the Chief Cardiac Anesthetist of Apollo Speciality Hospital, Chennai, and Dr. Azam, who is a consultant cardiologist and critical care specialist in Bhagwan Mahavir Jain Hospital, Bangalore. I also welcome today's speaker, Professor Dr. Satish Kumar sir, who is heading the cardiothoracic unit, CMC Vellore, and Dr. Hetal Kumar D. Shah, who is a clinical lead and a senior cardiac anesthetist in Narayana Hridalaya, Ahmedabad. I also welcome my fellow colleagues and also the presidents and secretary of various city branches and my dear postgraduates. I hope it will be a very good academic feast today. Thank you. Now I hand over the thing to Dr. Selvakumar sir for presidential address. Thank you.
Bhaskar, you are muted.
Thank you, madam. Thank you for
Yes,
your short introduction. I would like now hand over mic to our President-elect sir, Dr. G.P. Kriparan sir. Dr. Selvakumar sir, as unfortunately is unable to attend today's meeting due to some personal commitment. I would like to hand over mic to our President-elect Dr. G.P. Kriparan sir to give the presidential address.
Okay. Thank you, Bhaskar. Good morning. Yeah, pleasant Sunday morning to good morning to all. I'm privileged to conduct this meeting. 9th webinar of Tamil Nadu ISA, conducted by Vellore ISA City Branch. They have selected 2 super specialty topics and 2 super moderators and 2 super speakers also for this topic. So this session is going to be enjoyed by all the delegates, I'm sure. And I'm happy to introduce our moderator today, Dr. P.S.N. Raju. He needs no introduction. He's a very senior anesthetist and well-known among all of us. He's a chief cardiac anesthetist and intensivist of Apollo Specialty Hospital, Chennai. And he has got 5 publications to his credit, and he has presented more than 120 presentations in various academic forums. And he's a past president of IACTA also. And his areas of interest is LV restoration surgeries and OPCAB surgeries, critical care and hospital management. I welcome you, sir, for this session. And another moderator is, he is also a very well-known person, Dr. Azam. He is a senior consultant anesthetist and critical care specialist at Bhagwan Mahavir Jain Hospital. His special interests are regional anesthesia, critical care, obstetric anesthesia, and pediatric anesthesia. And he is very good in academics, so that he is appointed as academic advisor for ISA Karnataka and he's executive member of AORE, and he's a founder chairman of the Bangalore Anesthesia Review Course. And he's known well by all of us by his book. He's the author of the book, Dr. Azam's Notes in Anesthesiology. So he notes publications. And he has written various chapters in obstetric anesthesia textbook also. So without wasting much time, I welcome the both moderators to chair this session. And I hand over the mic to both the moderators. Please go ahead, sir.
Dr. Bhaskar.
So one thing, sir, I want to make one announcement. Anyone want to get the credit class, I will be sharing the link now, a Google form. Please fill the form and submit it, sir. So you can go ahead, sir. Rajesh, sir, you can take it. Thank you, sir.
Very good morning to all of you. I thank all the Tamil Nadu ISA board members for giving me this opportunity to moderate today's session. We have two interesting topics coming up. First topic of anesthetic management of tetralogy of Fallot patient coming for surgery, for a non-cardiac surgery by Dr. Satish Kumar. Dr. Satish is professor and head of the unit at famous CMC Vellore college. He is MD-DA and also he has got a MBA. And he is American board certified for the perioperative TEE. He is very academically active person and he is active in IACTA and also ISA. His areas of interest are cardiac anesthesia, TEE, and the bariatric anesthesia. He has about 19 publications and he has delivered many lectures at various national and state forums. I welcome Dr. Satish. It's a privilege introducing you.
Thank you, sir. Thank you very much, sir, for the kind introduction. Can you start, sir?
Yeah, you can. Yeah, you can proceed with that.
Yeah, I'm going to share my screen. Are you able to visualize my screen?
Yeah.
Yeah. Good morning, everyone. First of all, I would like to thank the ISA Tamil Nadu and Vellore City branch to giving me an opportunity to deliver a talk in this forum. My topic is anesthetic management of tetralogy of Fallot in cardiac surgery, and I'm working as a professor in Christian Medical College, Vellore. Let us go with the case scenario. A 3.5-year-old girl, baby, born a second of twins. It's a preterm baby presented with failure to thrive. The child was diagnosed as congenital heart disease elsewhere. The weight of the child is 11 kilos, height 91 centimeter, heart rate 114 per minute. All peripheral pulses are palpable. Saturation was around 88%, hemoglobin 17 gram percentage, and CVSRS, no specific signs. So with this history, we know this child is having congenital heart disease with cyanosis. The saturation is less than 90%. So how will you approach? What are the various causes for cyanosis in a child? The various congenital cyanotic heart disease conditions are truncus arteriosus, transposition of great vessels, tricuspid atresia, tetralogy of Fallot, total anomalous pulmonary venous congestion, venous drainage, Epstein anomaly, and Eisenmenger syndrome. So, which is the most common cyanotic congenital heart defect? As we all know, tetralogy of Fallot. Whether it is common at all age group, how to approach a cyanotic child. In the cyanosis present at the newborn period, it may not be a tetralogy unless it is extremely severe. It may be hyperplastic left ventricle, transposition of great arteries with ventricular intact VSD, and tricuspid atresia. And at the first week of life, it may be either pulmonary atresia or tricuspid atresia, transposition of great arteries. Only after 1 month, tetralogy of Fallot is more common. Why we commonly encounter tetralogy of Fallot? Because most of the other conditions are very severe abnormality, and these children may not make up. They may not do well even in the first week or first month of life. That's why we mostly encounter tetralogy of Fallot. But with the newer advent of surgery and medicine, many congenital anomalies are operated and they are doing well. In this patient, when we did a chest X-ray, it was showing like that. What is the shape of the heart here? it is a boot-shaped art, which is commonly called Karen's boot. Right? It is like this. The upturned cardiac apex is due to right ventricular hypertrophy, and the narrowest upper part of the boot results from a small or absent pulmonary artery. Here you see the boot upturned right ventricular shadow and the narrow apex. The ECG shows typically a right axis deviation and right ventricular hypertrophy. And when we did an echo, it is showing a large BSD, severe infundibular, valvular, and supravalvular pulmonic stenosis with a gradient of 80. Pulmonic annulus is 12 millimeter, and proximal main pulmonary artery is 8, and distal main pulmonary artery is 12 millimeter. What are these significance? So with this history and examination, we know this is a tetralogy of Fallot. What are the components of tetralogy of Fallot? What do you mean by pentalogy? What do you mean by trialogy of Fallot? In this picture, you can see the main culprit here is the ventricular septal defect. For that, overriding of aorta will be there, followed by a narrowing of pulmonic artery or the right ventricular outflow tract, which causes increased pressure overload, which results in right ventricular hypertrophy. So, ventricular septal defect, overriding of aorta, pulmonic stenosis, and right ventricular hypertrophy. These are the 4 components of TOF. This is a transthoracic echo, which shows a significant right ventricular hypertrophy, BSD here, and overriding aorta. You can see the left ventricle and also right ventricle, both are emptying into the aorta. And when you did the pulmonary artery view in the parasternal area, we could see the overall narrowing of the pulmonary artery and its branches, and cause significant turbulence when you do a color Doppler. Here, the main problem is due to the malaligned ventricular septum, which results in aortic overriding to cover the defect. Finally, because of the overriding, what happens? The right ventricular outflow tract will get obstructed in various levels. Finally, it increases the right ventricular pressure and finally hypertrophy. In pentalogy of Fallot, apart from VST, they'll have AST or PFO. So 5 components, that's why it's called pentalogy of Fallot. In trialogy, there won't be a VST, there is an AST, and there won't be much aortic overriding. See, we are talking about malaligned ventricular septal defect. What do you mean by that? This is the intact ventricular septum. Right atrium, right ventricle, left ventricle, and intact ventricular septum. This is a malaligned ventricular septum. The difference between the normal ventricular septal defect and malaligned ventricular septal defect is, here there is a defect, but there is no malalignment. That is a usual VST we come across in many asynotic arteries. But in TOF, there is a malalignment, mostly towards anterior deviation. So there is a defect. So for this covering this defect, the aorta will override. There are certain conditions with malaligned VST and posterior, which is not our area of interest today. Then what are the variants of TOF? Why the TOF manifests differently? Some patients are pink, some patients are blue, some patients have severe cyanotic spells. This is because of the degree of narrowing at the right ventricular outflow tract. It can be at the infundibular area, that is infundibular spasm, that is the right ventricular outflow tract, or at the pulmonary artery, supravalvular, or at the branch level. You see this definition, TOF with pulmonary stenosis can be either at subvalvular, valvular, or supravalvular area, or TOF will have severe pulmonary atresia. There is no pulmonary flow at all, or TOF with absent pulmonary valve syndrome, or TOF with atrioventricular septal defect, which is least common. So there are variants. We need to find out in the beginning itself which case we are dealing with. It has a very varied spectrum. There are different syndromes which associate with TOF. The most common is Downs. The others are discharge, Vactal, charge, Alagil, psoas, and so on. And any associated anomalies, particularly for the anesthetists, many patients will have some airway abnormalities or cervical spine issues that should be evaluated and addressed before you take up the patient for the surgery. What is the main pathophysiology behind this TOF? The main thing is pulmonic stenosis. Because of the pulmonic stenosis, it causes concentric right ventricular hypertrophy, right ventricular pressure overload, which causes right to left shunt, resulting in cyanosis. As the systolic pressure between the 2 ventricles are identical, there is no or little left to right shunt. Most of the time, the BST is silent, there won't be any murmur heard. Flow across pulmonary valve produces ejection systolic murmur. But if the pulmonary stenosis is severe, or if there is pulmonary atresia, there won't be any ejection systolic murmur because there is no flow, but the cyanosis will be performed. Extreme cyanosis will be present. So there is an anatomical and pathophysiological correlation in TOF. When you encounter a patient a pink color, that is a pink TOF with saturation more than 90%, there will be either minimal or no right ventricular outflow tract obstruction. But when you encounter a patient with significant cyanosis, less than 50%, around 30%, you can expect a severe or complete right ventricular outflow tract obstruction. Then the associated anomalies. What do you mean by MAPCA? MAPCA is major aortopulmonary collaterals. In this picture, if you see, the pulmonary artery is looking like a streak, a thin filament. There's almost no pulmonary artery. If this child wants to survive, there will be some other blood supply to the lung to survive. That's how it develops. There will be a lot of aortopulmonary collaterals develop and it supplies the lung. But some of these collaterals sometimes become very big, equal to a pulmonary artery size. That is called major aortopulmonary collaterals. Some patients will be having one, some patients will be having multiple. This has to be identified. What is the clinical significance? If this pulmonary collaterals is damaged, this patient can have severe cyanosis or they may not survive. Or if this patient is taken for surgery, this collateral should be identified and occluded before the surgery because it can cause major bleeding during the intraoperative period, pulmonary hemorrhage, or during the bypass, particularly when you do a cardiopulmonary bypass and then surgery, it will keep on filling the ventricle and impossible to correct the repair. Next important problem is coronary crossing the right ventricular outflow tract, particularly left anterior descending. Why it is important? Because when they want to do a corrective surgery, they have to open the right ventricular outflow tract from outside. If this coronary crosses the right ventricular outflow tract, it is impossible to do a corrective surgery. So these conditions should be evaluated and we have to identify before taking up a corrective surgery. Previously, we do a lot of cath study to find out all these problems. But with the advent of multi-detector CT scan with the 3D reconstruction, we can identify these problems without subjecting the child to invasive procedure like cath study. So in this picture, you can see a 3D reconstruction of anterior and posterior aspect of the heart with a lot of aortopulmonary collaterals. And this picture shows the branch pulmonary arteries and also the aorta and the coronary artery relationship. And in this particular case, there is a significant dilatation of the aorta and aneurysm because the aorta receives blood supply from both right and left ventricle. So all these problems can be identified without major difficulty, and this CT scan will take 5 to 10 minutes, not like cath study which takes more than an hour. And you may not need a airway intervention. You may need to give a short IV ketamine and do this procedure without major complication in these sick children. Next, come to the important aspect, that TET spell. Why it is a vicious cycle? We all know that TET spell is mainly due to the acute decrease in systemic vascular resistance. Whenever there is fall in SVR, there will be automatically a right to left shunt increases because already the right ventricular pressure is higher. So once if the shunt increases, the PO2 and PO2 decreases and PaCO2 increases, which results in decrease in pH. This decrease in fall in pH causes increased hyperapnea, which is a reflex response when the child is awake, and which results in deep and rapid breathing. Further increases the negative intrathoracic pressure. Venous return will increase to the heart, finally land up in vicious cycle of further shunting of blood into the left side chamber from right to left. How will you break it? If the child is under anesthesia, you need to increase the inspired oxygen concentration to reduce the hypoxia. Next is increase the left ventricular afterload by administering intravenous phenylephrine at an aliquots of 5 to 10 microgram per kilogram. Apply abdominal compression. How will you do it? Either by hand compression or do a knee chest position. If already the chest is open, the surgeon can manually do a surgical compression of aorta. Increase right ventricular preload also will reduce the shunt. This can be done by administering intravenous fluid boluses, or the applying abdominal compression will help in both increasing the SVR and increasing the preload to the right heart. Particular cases with infundibular spasm, we need to break the spasm. The commonest drug which is used to break the infundibular spasm is beta blockers. Esmolar, short-acting beta blockers, Esmolar can be used at an liquids of 50 microgram per kilogram. And you can increase the depth of anesthesia. Previously, in the golden era, we use halothane. Now it is out of use, so we use sevoflurane that also gives equal effect by reducing the spasm. What are the various areas we encounter managing the TOF? Apart from ward as TET spells or in the ICU, we encounter these patients in cardiac catheter labs. Suppose if the newborn is having significant cyanosis, profound cyanosis, unable to survive, the child can be immediately rushed into the cath lab to do a pulmonary valvotomy to improve the blood supply according to the anatomy. Or suppose if the PDA is about to close, and only through PDA, that is patent ductus arteriosus, so only through that, if the child is getting blood supply to the lung, then it should be stented to prevent further hypoxia. These are the conditions where we encounter these children. These children are very sick, intubated on inotrops. Next is a temporizing or palliative surgery, that is a shunt surgery. This is a systemic to pulmonary shunt. When the child has profound cyanosis, in the early neonate period, they will do the shunt surgery, which I will come across later. And then corrective surgery, that is the definitive surgery, VST closure or with RVOT resection and patch or a transannular patch. Before going through the management, first we need to assess this patient preoperatively and advise accordingly. First and foremost is look for the cyanosis and degree of cyanosis, which is proportionately correlate with the polycythemia. The more the cyanosis, more the polycythemia and the associated problems. And when the polycythemia is significant, these patients are prone for severe dehydration and stasis. So avoid dehydration in the preoperative period and also avoid significant fasting duration in this child. If you're worried, start an IV cannula the previous day and start hydrating the child. And the beta, if the infundibular spasm is a significant issue for the hypercyanotic spells or the condition, we need to continue the beta blockers. Most of these children will be on beta blockers, continue that. Next important thing is coagulation abnormalities. With the profound cyanosis and polycythemia, these patients are prone to significant coagulation abnormalities, particularly platelet dysfunction. This should be evaluated preoperatively and discussed with the blood bank and blood bank officers and find out the best possible products to be given during the perioperative period. Next important dilemma is whether to give sedative premeds or not. This is always a confusion. If the degree of cyanosis is severe and the patient is having hypercyanotic spells, it is not advised to give a sedative premeds. If you place an IV cannula for hydration, can be used to give a small dose of ketamine like 1 milligram per kilogram in the receiving area of the theater and take the child inside the theater. But if it is a pink TOF and the cyanosis is less profound, we do give sedative premeds because the crying children is always a trouble and also that will aggravate the cyanotic spells. So we used to give trichlorophos 75 milligram per kilogram, 1.5 hours pre-operative. Next comes to the anesthetic management. Whether you do inhalational or intravenous. As we all know, these children, am I audible? Sorry. Excuse me.
Yes, sir, you're audible, sir. Very much audible.
Audible.
Thank you. The next important thing is inhalational or intravenous. See, these children have very less blood flow to the lung. The pulmonary system is totally not much developed. So inhalation will take long time and sometimes it may be difficult to put them under sleep with inhalation alone. So for everybody, I will advise intravenous induction may be safer because it will quickly take the child, because the right to left shunting is that the child will induce very faster. So most common drug is ketamine, 1 to 2 milligram per kg. And we can titrate a small dose of fentanyl also according to the hemodynamics and then paralyze the child. Our primary motive in this children, when you induce these children, is to avoid fall in SVR at any cost. You need to prevent or prophylactically treat the SVR before it falls. Most of the time, phenylephrine is anti-drug, 10 to 20 mics can be titrated. Next important thing you should consider is prevent hypothermia. One thing is hypothermia can cause significant coagulation abnormalities, and also when you bring the child and put them in a colder environment, they immediately start waking up, start crying, and it gives a lot of trouble. So before taking the child, make sure the theater is warm, keep your warmers ready, and sheets also, warm sheets, and then take the child and start inducing inside the theater. This is the ideal way of teaching the child. This, if the child is having less profound cyanosis, can be done, but most of the time we'll end up using IV sedation, IV induction. What is meant by shunt surgery? Here, there are a lot of shunt surgery, but the most common one is modified Blalock tossing shunt. They use a synthetic graft, vortex graft, connecting the right subclavian artery to the right pulmonary artery. It's a side-to-side anastomosis. The classic Blalock is end-to-side anastomosis by cutting the left subclavian to the left pulmonary artery. There are portion which connects the left pulmonary artery to the ascending aorta, Watterson which connects the ascending aorta to the right pulmonary artery, and there are central shunt which connects right ascending aorta to the main pulmonary artery. What are the problems? Why these shunt surgeries are conducted? What are the indications? Whenever there is a severe RVOT obstruction in neonates and there is a child cannot survive, these children are subjected to shunt surgery. And preterm infants, when they are very small, very difficult to undergo complete repair, those children are subjected to shunt surgery. Medically refractory hypercyanotic spells, or if the coronary artery anomalies which prevents early repair, or infants with severe pulmonary hypoplasia which is impossible to do a corrective repair immediately, then these children are subjected for shunt surgery. What are the anesthetic challenges to them? Most of this time, this anesthetic these shunt surgeries requires either thoracotomy or sternotomy. Some surgeons do this shunt surgery under thoracotomy. You can imagine that already the children are cyanotic, and if they do thoracotomy, again you have to retract the lung, or you need to isolate the lung, which further reduces the oxygen saturation. So it's a big challenge for an anesthesiologist. We need to make a good plan. Most of the time, we may not need to collapse the lung because the surgeons are very used to retract the lung and do this anastomosis, because otherwise the child may not tolerate, and adequate pain relief and hemodynamic management. These children, most of the time, because inotropic support during the perioperative period. It can be to avoid all these problems. Many surgeons do under sternotomy, under bypass, which gives much more relaxed time so that they can do it appropriately without much struggle. But whatever happens at the end of the surgery, don't aim a very high saturation, because you aim around 75 to 85%. If you aim a high saturation with high FiO2, the pulmonary vessels start dilating, and this shunt flow profoundly into the pulmonary system, which is not capable of handling such an hyperperfusion, can result in pulmonary edema, pulmonary hemorrhage, and also causes significant desaturation. So this should be avoided. And for an early recovery, adequate pain relief is very important. In our center, we do use paravertebral block with the local anesthetic and dexmedetomidine, which helps in postoperative recovery very smooth. Next comes the corrective surgery. What are the corrective surgery they do? Because the VST is there, they have to close the VST. They have to open the right ventricular outflow tract and resect the infundibulum spasm and patch enlargement of the RVOT with pericardium. But if there's a pulmonary valve is stenotic, they might do pulmonary valvotomy. But if the entire anatomy is so bad and if they cannot do only RVOT patch, they have to open the pulmonary artery across the pulmonary wall into the right ventricular outflow tract, as in this figure, and they put a big patch. This is called transannular patch. Suppose if the branch pulmonary artery also involved, they have to do a branch pulmonary artery reconstruction. What is the advantage of transannular patch or versus valve sparing repair? Transannular patch, if you put a big patch across, there won't be residual stenosis, but long term, they'll have severe pulmonary regurgitation, which results in RV dilatation and RV dysfunction. But in valve sparing repair, which is commonly done in most of the centers nowadays to prevent all the late complication, it reduces the pulmonary regurgitation, but there will be a residual stenosis And over a period, it improves. Many centers have proven that over a period, the gradient comes down and the child will do well. So nowadays, most of the center practice valve sparing repair rather than transannular patch. What are the anesthetic problems or challenges in this type of corrective repair? As I mentioned already, sternotomy and cardiopulmonary bypass is very important to do this surgery. Already these patients having coagulation abnormalities. When you subject this patient for cardiopulmonary bypass with all the heparin and hemodilution, further coagulation abnormalities will happen. So that should be tackled. Tranexamic acid should be started from the beginning. It is a class 1 indication. And you need to discuss with the blood bank and the hematology doctors early, and with the combined point of care testing, we can give the products and other blood and blood related blood derivatives to overcome the issue post-operatively. Next important monitor, apart from the usual NAB, arterial BP and ECG and central venous pressure, is transesophageal echo, which can be used pre-bypass and post-bypass to check the defect and also the completion of the surgery, and also assess the right ventricular function, particularly right ventricular function. Here, the most challenge is right ventricular dysfunction in the post-operative period. These are certain images pre-CBP we have taken. This shows a narrowed right ventricle. This is a right ventricle, and this is the pulmonary outflow tract. This is such a significant narrowing with the turbulence and the gradient across it. And post-repair, you could see they put a patch and the narrowing is slightly enlarged, and the defect is, and then turbulence become less. And here in this echo image, you can see the VST is closed. This is a right atrium, left atrium. This is the interventricular septum. There was a defect which is closed, and there is no residual defect there. The major post-operative complications are the major concerns in these top patients. Even though surgery becomes uneventful, post-operatively they may develop significant problems, either due to a residual defect like residual right ventricular outflow tract obstruction, or residual VST, or significant pulmonary insufficiency, which can cause RV dilatation or RV or LV dysfunction. And since the aorta is overriding and covering major portion of both ventricles, sometimes it can get injured and cause aortic regurgitation in the post-op. So that also to be checked before shifting the patient to the, from the theater. And in the post-operative, any complication that should be ruled out. And these patients are prone for many arrhythmia, particularly atrial tachyarrhythmias, because a lot of conduction system is involved from the right atrium to the right ventricular outflow tract. So those problems should be addressed according to the issues. With this, I'll complete my talk. Thank you very much. This is our campus, new campus. Thank you.
Bhaskar sir, Raju sir, you're there?
Yeah. Thank you, Dr. Satish.
Thank you.
Nice and crisp presentation, and such a difficult topic. You made it simple and covered all the aspects of tetralogy of Fallot, which is a difficult case to manage for any anesthetist.
Yes.
And, request for any questions and comments.
So there has been one question in the chat box.
Yes.
Yeah.
What question, sir? I could not see, sir.
There is some question saying that increased RV preload won't cause fluid overload. Does it cause fluid overload? This is from Dr. Purnima Soundarajan to Dr. Satish. Does increasing the RV preload cause a fluid overload during a spell?
See, yeah, see, that's a good question. Actually, the RV is significantly hypertrophic. Unless you maintain a RV preload, your systemic perfusion is really at risk in this patient. If you're hypovolemic, if the patient is hypovolemic, the RV cannot contract also. And this system is very complicated. It depends upon the RV contractility. So if you don't maintain the RV preload, your systemic perfusion will get affected. That's why this patient should be hydrated. And next important thing is stasis. If you don't adequately preload, the stasis is going to worsen. Already there will be significantly polycythemia. For these two reasons, the preload should be very essential to maintain the system circulation. Is it clear?
Yeah, chance of pulmonary edema and pulmonary congestion is very, very, very rare.
Very, very
with
rare.
the tetralogy. It doesn't happen. So we can liberally give fluid. That's what we teach our postgraduates and juniors. In a case of tetralogy, always hydrate well, give more fluid.
Yes, already the pulmonary system is underdeveloped, hyperplastic.
Yes.
So you may not get pulmonary edema in this patient.
Edema at all.
At all.
Any other question?
So you can put some practical points on to sir, Raju sir.
Yes. Yeah, always tetralogy. We are also getting this patient for non-cardiac surgeries also. I think that is of a lot of importance to all the postgraduates. As I said, the hydration is very, very important. Other thing is these are small children, and when we keep them in NPO status itself, they tend to get hypovolemic, and that can precipitate a tetralogy spell, TET spell. So we should minimize the NPO time as much as possible when we are keeping, for example, the TOF coming for another incidental surgeries. We should reduce the NPO timing, or we should give IV fluids and hydrate the patient very well. That is one point I always tell my student. Second point is crying and stress itself. If the patient is struggling, a child is struggling and crying, that itself also can precipitate a TET spell. So we need to sedate them, give some oral sedatives so that the patient is calm. And then when they come to the theater, they're not struggling, because the child is struggling, more chance of getting into a TET spell. Satish, you are doing a lot of
yes, sir. Most of the time, we encounter these patients for tooth extraction. Lot of caries tooth will be there. These children, before surgery itself, they'll be subjected for tooth extraction under GA. So it is a challenge, and definitely, at least in cardiac, when they come for cardiac surgery, at the end, there's a defect is corrected. Here, we have to extubate a patient with the same problem. So both intubation and extubation, both are challenges. Hydration, as sir mentioned, hydration is very important. If you don't maintain the hydration, the patient will trouble. Don't make the child cry. Either it's a small dose of, that's a balance. So as sir said, a small dose of sedative treatments definitely helps. And you need to monitor. You need to monitor and take the child calmly, and then induce the child and make things better, and keep all your drugs like phenylephrine and everything ready, diluted according to the body weight, so that whenever there is a small, even anticipation is very important, and treat accordingly before you develop a severe cyanotic spells, because if you develop severe cyanotic spells, very difficult to handle on theater. That's very important. Next thing is, sometimes they may call in the patient will be in the preoperative period in the ward. If you are closely working with the surgeon, suddenly they may call you in the ward. The patient is having hypercyanotic spells. When you go there, the first and foremost thing you should do is knee chest position. That immediately, because in the ward, you may not have much. You may not have an IV access or any other drug available. Sometimes oxygen itself in the ward, we don't know where to connect and all those things. So knee chest position will help increasing the preload and also increasing the SVR, which is the first step you have to do, and tackle the situation immediately. Subsequently, you can manage with the support.
Dr. Hetal, you want to add?
Yeah, so another thing which these patients can come, tough patients for, is for craniotomy. So they do have because of the polycythemia, they do have a lot of viscosity, and that will cause a brain circulation. Sometimes they get a ischemic infarct, And this ischemic infarct tend to have, because of low oxygenation, they tend to have a infection. So they come with most of the time either with the infarct
Abscess.
or cerebral abscess. So these are very challenging because they would have not been corrected from heart point of view, and you have to take a very high major surgery like craniotomies with them. And the another important thing when you are, I mean, the people who are listening, is that when you're taking the history of these patients, they may not give you the TET spell histories because they may not be understanding what is the TET spells. So what I do when I go there is that when this child is crying or when this child is playing, I ask always this to the parents that how much they exert or how much they play and what happens at the end. So if they sit in the knee chest position itself, that they are getting into the spells and they themselves have understood that this position is giving them relief. So these patients are more sicker as compared to the other patients. So tricky history would also help you that these patients would be having a TED spells. So that's what. But good presentation, Dr. Satish.
Thank you.
Dr. Azam. Dr. Azam.
Yes, sir. I think it
Yeah.
has been, yeah, sir. Thank you, sir. Most has been discussed, I think, sir. Excellent presentation, Dr. Satish.
Thank
I
you.
learned a lot of things. Thank you.
Dr. Kumar.
Yeah, very good morning, sir.
Very
Sorry,
good morning.
sorry, I joined a little late because I held up in putting an IABP in the morning. And
Any points to add here for
it's a
the
very good, very good lecture by Dr. Satish. Satish, good lecture, man.
Thank you, sir.
Sir, as you said, in non-cardiac surgery, we have to take care of the hydration status, number 1. Number 2, SVR reduction should be avoided. Number 3, coagulopathy should be expected in all major non-cardiac surgeries because of polycythemia and coagulation parameter alteration due to cyanosis. And number 4, we should get ready for treatment of TET spells. Cyanotic spells in non-cardiac surgery can occur, that should be addressed. These 4 are important in non-cardiac surgery. In cardiac surgery, the same thing, except TET spell, because we are going ahead with surgery. Except TET spell, the most important should be, as Dr. Satish mentioned, MAPCAS. MAPCAS is killer that can produce pulmonary hemorrhage and postoperative ARDS, and then shunting. All those things are a major problem in MAPCAS. So that should be addressed before going ahead to the correction of TYF. That's it. And I wanted to have some clarification for the sake of discussion, for the sake of our colleagues. Satish, do you have the practice of venesection before going ahead with any surgery for polycythemia still?
Yes, yes. So suppose if the hematocrit is more than 55-60, we still do venesection because it may cause a lot of stasis and difficult to handle the pump also, because when you go on pump, the hemoglobin will be more than 10. Then it is difficult to run the pump also. So we do venesection if you come across a profound cyanotic patient with high polycythemia, but not less than 50 hematocrit, we are not doing it.
Okay, your target is 50.
50.
Okay.
15 or 16? 16.
Okay. Then you are having a lot of stenting, structural heart disease like that. Is there any experience with RVOD stenting in your center?
RVOT stenting, not really. Pulmonary valvotomy we are doing, and PDS stenting. Sometimes the neonates, we have a very good neonatal ICU, and if they are duct dependent for the top children with the duct dependence, then they bring in for stenting of the duct. These kids we have done with they'll be on, sometimes they start prostaglandin, but even with the prostaglandin it may not settle, so they bring them for stent surgeries.
Okay.
RVOT stenting very rarely because the RVOT is already very well developed, very difficult to place a stent there. So we are not doing that RVOT stenting.
Okay. Dakshiva is doing, but what about your center? That's what I asked. Okay.
Yeah, I've been privileged to have a post of pulmonary regurgitation. So we put a malady valve in pulmonary position percutaneously. So yeah, we did one.
Great.
Yeah, we do use our structural heart disease people. They put a stent inside that, they put a valve, and these patients are around 45-50. That's why the transannular patch is not considered nowadays, because olden days they do all transannular patch. Even our center previously they were doing transannular patch. Because a lot of pulmonary regurgitation and RV dysfunction at the age of 40-50, and the patient cannot do well. So they, with this melody valve, they are doing a lot of pulmonary interventions there.
Thank you. Thank you.
I think we had a good discussion. If there are no other questions and comments, I pass on to Dr. Azam, my co-moderator, to take over and conduct the session. Dr.
Thank
Azam.
you.
Thank you.
Thank you, sir. Thank you so much. Thank you, Satish, sir, for an excellent update on this. In fact, we do a lot of we do get a lot of cleft lips and cleft palates. In fact, we are the first center in Asia and fifth in the world. So we get a lot of these heart diseases for cleft lips and cleft palate repairs. So when we get this TOF, we do get a first prior cardiac opinion, and then we go ahead. So thank you so much once again for this such a wonderful update. And Bhaskar sir, can I continue with your permission?
Yes, sir. Please, sir. You can start, sir. You can go for the second session.
Yes, sir. So thank you so much once again. I get greetings from Bangalore, Karnataka. I first of all thank the entire Tamil Nadu ISA for giving me an opportunity to be moderator here. And today I'm going to introduce Dr. Hetal. Dr. Hetal Shah needs no introduction, but however, he is the clinical lead and anesthetist and a cardiac anesthesiologist and critical care specialist at Ahmedabad. He has 16 years of experience. His special interest being pediatric cardiac surgery, airway, critical care. He has achieved a lot. His awards are Chairman's Award for the Best Doctor in the Group and Dr. Cope's Award by ISA in 2021. He has 7 publications against his name, and he's been the secretary for IDA Ahmedabad City branch, and he has given lectures at innumerable lectures across India. Dr. Hetal, thank you so much, and over to you, sir. You can share your screen.
Yeah, thanks for the nice introduction, Azam. Azam is a good friend. Is my screen visible?
Yes, sir. And you can go into the full screen.
Yeah, is it full screen now?
Yeah, perfect. Yeah. You're audible also.
Fine, thank you. So at the outset, I would like to say good morning to all of you and greetings from Ahmedabad, I think the hottest city of the day today. And definitely thanks team ISA Tamil Nadu for giving me this opportunity. My topic would be this cardiac devices and anesthesia for patients who are having a pacemaker or other devices which is implanted in their body, and if they come for the anesthesia, so what precautions we need to do and what we need to do. So let me start with a case which is a female of 63-year-old which is posted for total hip replacement, and she came for PSA, and obviously because of the age we got an ECG done, and this is the ECG which shows that patient is having a almost 3:1 block with very less atrial ventricular rates of about 40 to 50, and she is having some ventricular ectopics which is showing almost RNT kind of phenomena. So we got definitely we got a cardiologist reference, and cardiologist suggested that this patient needs a pacemaker before we proceed for the surgery. So what would be the anesthesia challenges with this patient? So they would be definitely requiring some anesthesia for permanent pacemaker implantation. After the permanent pacemaker, they would come for their native like THR surgery. They would be requiring some other surgery in future, and they would be requiring a battery replacement for the pacemaker later on. So these are the chronic patients for an anesthesiologist, and that's why we need to understand what to be done with this kind of category of the patients. What is pacemaker? Pacemaker is a surgically implanted electronic devices that regulates a slow heart or erratic heartbeats. Right? What are the let's go for the challenges. So if this patient posted for permanent pacemaker, before we go for the anesthesia plan, what are the indications for permanent pacemaker? And let me put it this way, that it's a big final today. And if you, in between the match, if you skip your heartbeat, would you be needing a pacemaker? The answer is no. So these are the indications for the pacemaker. I mean, it could be a sinus node dysfunction, AV block, chronic middle branch block, or other conditions where this patient would be needed pacemaker. And the good part is that the permanent pacemaker implantation usually done under local anesthesia and mild sedation is required. If they usually put it through the subclavian route, mostly prefer left subclavian. So they make a pouch over here. So if you give a good local anesthesia over here or some block with some kind of mild sedation to tolerate that procedure, usually they start with a temporary pacemaker, which is done under local anesthesia, and then they would put this pacemaker. So it's most of the time it is done under local anesthesia and sedation. Before we proceed, now these patients would be posted for some kind of surgery. So before we proceed, we need to understand about the basics of device, right? So there are multiple types of devices are available. The first is unipolar or bipolar. Unipolar will have only one electrode which is placed at the endocardium. Why need to understand this? Because the more electromagnetic interference happens with this kind of pacemaker. So if your patient is having a unipolar pacemaker, you should be very, very careful about the electromagnetic interference during surgery, because that will defunk the pacemaker and it may stop working, or it may erratically start working, and then that can create a problem during surgery. But if you have a bipolar pacemaker where you have two electrodes, one is near to the endocardium, the other is somewhere a little away from that, and these bipolar pacemakers has less electromagnetic interference. So you have to understand whether your patient is having a unipolar pacemaker or a bipolar pacemaker. The another one are the asynchronous or synchronous pacemakers. Now, what is asynchronous pacemaker? Asynchronous pacemaker are set at a particular rate and they don't think anything. So they would give, let's say, if the pacemaker is set at a 80 rate, irrespective of the rhythm, it will give 80 rate. So that is very, very important with the patients who doesn't have a very ventricular activity. So they don't, if the patient is having a less heart rate, or let's say about 10, 20, 30 kind of thing. So it is very important and very good for this kind of patients. But if the patient is having some amount of ventricular activity, let's say its ventricular beats at around 60 or 70 rate, so that may compete with the pacemaker rhythm also, because this pacemaker are tuned to give a set rate. So sometimes they may induce a ventricular tachycardia if R1T kind of phenomena happens with the competition between the intrinsic rhythm and the pacemaker rhythm. And if that generates R1T, and that can cause VT. So this is very important. If the patient is on asynchronous with good ventricular activity, this can problem. So how do you know that this patient is on asynchronous pacemaker? So you see the mode of pacemaker. So if it is on a VOO, AOO, or DOO, that means this patient is having an asynchronous mode of pacing, right? The another is a synchronous pacemaker. This is the most frequently used pacemakers, and the advantage is it eliminates the competition. So whenever the patient's intrinsic activity comes, it doesn't pace, right? And that's why it is more energy sparing, because it will uses less battery, so their battery replacement becomes very late. So that is energy sparing. So these are most frequently used pacemakers, and it is very useful to the patient also. Another thing which you need to do from hemodynamic point of view is that whether the patient is on a sequential pacemaker or a single chamber pacemaker. So what happens in a single chamber pacemaker? So this is a pacemaker battery, and there is a pacemaker wire which is going into the ventricle. There is only one wire. So this pacemaker only does pacing to the ventricle. While in dual chamber pacemaker, there are two wires. One is going to the atrium, one is going to the ventricle. Now, what is advantageous is that in the dual chamber pacemaker, the sequence between the atrial contraction followed by ventricular contraction is maintained. So that will maintain the cardiac output. So that compared to the single chamber pacemaker, dual chamber pacemaker patients would have a 15 to 20% more cardiac output, and it's like a normal synchronous rhythm. So they would have a less hemodynamic issues as compared to single chamber pacemaker patients. So that is from hemodynamic point of view, you need to understand this. So how do you know? I know that this patient is having asynchronous, synchronous, single chamber, dual chamber, or any program has been done into this patient. So that's why you need to understand the coding, which I said VO, DO, AO. What does that mean? So you have to understand the coding. If you understand the coding of the pacemaker, you will understand that what kind of pacemaker the patient is having. So the first letter, as I said, VOO or DOO or AOO. So what is that first letter means? The first letter means that the chamber, which is the chamber, is going to become paced. So that chamber is the chamber which is going to be paced by the pacemaker. So if it is written A stands for atrium, V stands for ventricle, D stands for dual, and O stands for none. So, I mean, very unlikely that the first letter will be O. So, it will be either A, V, or D. So, either atrium is being paced, ventricle being paced, or either dual, both chambers are getting paced. So, that first letter indicates the chamber being paced. The second letter indicates the chamber being sensed. Again, it's AVDO. So, which is the chamber? So, there is a signal which is going to the machine. That is, signal is been sensed by the pacemaker, and according to that signal, the pacemaker has been pacing that first letter chamber, right? And the third letter is what is the generator's response. So, whatever the signal which has come to the machine from the second letter chamber, and what the generator has to do with that signal. So either it could be inhibited, or it will inhibit, so that means I, or it will trigger the rhythm, or it may do the dual thing. The smarter generation pacemaker can inhibit or trigger, depending on the signal they will decide, or it will be O, which is asynchronous. So wherever the third letter is O, that means it is asynchronous. It is a pacing which has been fixed at a particular rate, while ITD, any of this third letter, will tell you that this is a synchronous kind of pacemaker, right? So like it's AOO, that the atrial is going to be paced. There is no response to the signal which is coming, and there is no asynchronous pacemaker. Same way, ventricle is being paced. There is no chamber which is going sensed, and it is an asynchronous. When it is, let's say, VVI, which is very common. So ventricle is being paced, ventricle is being sensed, and if there is any ventricular activity, it will give inhibition, so that machine will not pace. So let's say this patient is VVI. So ventricle is the pacemaker chamber which is going to be paced, but the sensing will come from the ventricle. So if there is any ventricular activity, own ventricular activity, the machine will sense that and it will inhibit. So the next machine will not give anything. So there will be a non-competitive kind of thing. DDD is the another common thing which is the pacemaker which are there. So it will sense and pace both the chambers, and it will have both the response, whether it's a due sensing, you inhibit the response, or you pace the response. So DDD is the most common and most smart kind of machines which people can have. So this is the coding which we need to understand, and that will tell you a lot of things about pacemakers. Now, if this patient is posted for THR surgery, or let's say any patient who is coming, which is having a pacemaker implantation or any cardiac devices which has been implanted, and she is coming for any surgery. So what is important in the history which you need to know? So the very, very important thing which you need to understand is when it was done and when was it been last evaluated. Now, this is to be understood about the battery status of these patients, of the machines. So if the last evaluation is done very long back, that means we don't know the status of the battery, and it may happen that during the surgery the battery may get over, and no patient will have an issue. So it is very, very important to understand that when it was done and when it was been last evaluated, where it was done, so which hospital it will be done, so that if you have any issues, if you want to understand something, you can contact those people, those cardiologists or electrophysiologists, and they can guide you better. And which anatomical location of pacemaker has been placed, because that is very, very important in terms of magnetic field generation. So this anatomical location of pacemaker is also very important. Why it was done, so that will help you, that if the pacemaker becomes defunct during surgery for any of the reasons, so you know that this is the patient is having a basic problem of this, and then you can prepare yourself, or you can keep in pre-operative preparation, you can keep things ready if anything goes mishap happens with the pacemaker during surgery. What mode patient is on, so that will tell you about the synchronous, asynchronous, what kind of chamber is getting going to be paced. It is a unipolar, it is a single chamber pacemaker or a double chamber pacemaker. What is the battery status? And if the patient is having a device which is giving SOCs, so which is called ICDs, implantable cardiac defibrillators. So whether these patients are getting SOC or not. So if the patients are getting SOC, that means these patients are prone for arrhythmias. And if these patients are prone for arrhythmias, then you have to be ready with your antiarrhythmetics during surgery. And how? So if there is any functional issue with the pacemaker, if the patient needs frequent monitoring or he has to go to frequent to the visit for the pacemaker thing, then you can come to know. And that is why very, very important that you need to have a ECG for all these patients. Now, ECG will tell you what? Sorry for moving forward. Yeah. So 12 lead ECG is very, very important because it will give you a lot of indications. So let's say this is the ECG of the patient who is having pacemaker. You are getting all the pacemaker spikes, right? But what is happening is after this pacemaker spike, you see there is a P wave. After all pacemaker spikes, there is a P wave, and QRS complex is relatively narrow, right? So this means this patient is on a solo atrial pacing, right? So that will also tell you, and then it is functioning very well. Let's say if you have this kind of ECG where you are getting the pacemaker spikes and then followed by wide QRS complexes. So that means this patient is in a solo ventricular pacing. So this will come to know that this patient is having a single chamber pacemaker, which is a ventricular pacemaker kind of thing. X-ray chest is very, very important because that will tell you about the information about what kind of devices, or if this device is having a malposition, that also can be done. I'll show you the few X-rays. So as I told you, there will be a single chamber pacemaker where you have one lead. There is a dual chamber pacemaker where you have two leads. But in these patients, if you can see, this patient is having three leads. One is RA lead, one is RV lead, and there is one another lead which is going like a sitting chair position lead. This is the lead which is going through the coronary sinus, and this will be doing a pacing for the left ventricle. So whenever you see the third lead and which is having a sitting chair kind of position, that means these patients are on a CRT devices. Now CRT is a chronic resynchronization therapy, and this will be useful to the patients who is having a low ejection fraction. So from the X-ray, you don't see that the heart is very big, but this patient is having a CRT device. That means this patient's ejection fraction is very low. So without doing echo, I can understand that this patient's having a low ejection fraction. So these are the CRT-P kind of devices. These are the newer generation leadless pacemakers where you can just see some kind of some sort of a spring into the heart and you don't see any wires. These are the leadless pacemakers. Yeah, this is a new thing which is coming in the market, and this works on a Wi-Fi, right? This is the device where you can see the device. There is wire which is going, and it has a more longish radiolucency. So this is the shock giving area, and this means that this patient is having a device which is having a defibrillator kind of function, and this is a CRT. This is ICD, which is intracardiac defibrillator. So this patient is prone for arrhythmia. So this will all indicate you from the X-ray itself, right? This is the device where RV lead is migrated out of the RV. Now that's more dangerous because it is not attached with the endocardium, so it will not functioning properly. And this RV lead, which is migrating out of the RV, can cause issues perioperatively. So this needs to be fixed first, right? So the X-ray will tell you a lot of things, right? And as I said, that when this device has been deployed and when this device has been lastly evaluated, so what are the timeframes which we can accept, right? So according to the Heart Rhythm Society recommendations, if the patient is have a conventional pacemaker, and if it has been evaluated within last 12 months, it is fine. For any AICDs, that is implantable defibrillator devices, it should be evaluated within last 6 months. And for CRT or CRTD kind of devices where the patient is having a poor LV function and they have a chronic resynchronization therapy, it should be evaluated within last 3 to 6 months. So this is the standard guidelines from the Heart Rhythm Society. So if your patient been evaluated during this time, it is fine. You can proceed. You don't have to reevaluate those machines. But if it is not done in this speculative time, then probably you may have to do a check by the company person, right? And how do you know that the patient is having a pacemaker dependency? So the ECG will tell you. So if the patient is having a ECG where having a pacing burden of more than 40% or predominant pacing rhythm in ECG, which we have seen in last two ECGs, right? So that means this patient is having a pacemaker dependency. Now, this is very, very important to understand if the patient is having a pacemaker dependency and during surgery, because of electromagnetic field or because of some reason, if the pacemaker start defunctioning, then these patients will not have any own intrinsic rhythm, and then they may challenge you. So that's why you need to have all the things ready, maybe like temporary pacemaker or cardiac personnel or a company guy or drugs to resuscitate. So that is where it is important to understand from the ECG that whether this patient is on a pacemaker dependent or not. And there are certain devices which we need to reprogram before the surgery. So most of the questions is that when I get some of the colleagues who's having a pacemaker patient for surgery, and he will definitely ask me whether I need to call the company person, whether I need to reprogram these machines or not. So these are the indications for reprogramming. If the patient is having a significant pacemaker dependency, definitely you need to reprogram them into the asynchronous mode. If the patient is having a defibrillator function, so patients are posted having ICD kind of devices or CRT-D, you definitely have to stop this defibrillator function, because any about the cautery or any movement, let's say if you're given a succinylcholine of or patient is having maybe a muscle twitches or patient is having shivering, that will be considered as a arrhythmia, tachycardia, and defibrillator will unnecessarily shock this patient. So patients with a significant pacemaker dependency and defibrillator function definitely needs to be reprogrammed, right? That's very, very important. So that's why ACC-AHA guidelines is all anti-tachycardia therapy to be disabled before anesthesia. So these are the two definitely indications where you need to reprogram pacemaker before proceeding to the surgery. Now, as I said, what is the anatomical location of that pacemaker, which is very, very important. So if your anatomical location of the pacemaker and the surgical site is remote, then there is a less chance of malfunction. But if it is close, these two places are very close. Let's say if the pacemaker is done on supramammary area or just below the clavicle, and if you are having a surgery which is on the thorax, then or in the upper part of abdomen, then there is or head and neck surgery, then there is a more chance that these patients will have a during surgery malfunction of pacemaker is very, very important. But if the surgery is on the leg, below knee surgeries, then there's a remote chance that this patient will have a malfunction, right? What need to be monitored intraoperatively? Continuous ECG and peripheral pulse is must. Pulse ox with plethysmography to see the perfusion of the patient, so that they should be having a good cardiac output, so they don't land up in perioperative low cardiac output state and morbidity. Defibrillator and crash cart should be available. Drugs to resuscitate ideally to be kept ready, and you should have external pacer or external converter magnet should be available to this patient, and if feasible, availability of appropriate cardiac personnel. When you conduct anesthesia for this patient, you try to avoid the succinylcholine, because that will cause a lot of fasciculation and it may cause generator to defunk. Electromagnetic fields, electrocautery, which can behave erratically. It may inhibit, it may trigger, it may generate arrhythmia, it may lead to asynchronous mode. Anything can happen, and there is no fixed response to what these machines will do to this electrocautery. So that's the basic question, that whether we can use cautery or we cannot use the cautery, and that's what is a basic question. I'll come to that. And these are the electromagnetic interference generating factors intraoperatively. So this should be avoided or used in a very guarded manner. So whether to use cautery or not to use cautery. So the answers would be, you place grounding pads as far from the generator as possible and as near to the surgical field as possible. So cautery has cautery pencil and the pad, which is working as an earthing. So that pad has to be gelled well. It should be covered well with the conductive gel, and it should be very close to the surgical site and far from the pacemaker site. And use bipolar cautery if possible. Even with bipolar cautery, is that surgeon must use short burst of electrocautery. So it could be a less than 1 second burst of cautery they should use, so that it will not cause dysfunction of any pacemaker. It should maintain the lowest possible current The cautery should not be at a 40, 50, 60 ampere to use. It should be using the whatever the lowest possible for the surgeon. If pacemaker inhibition occurs, if you feel from the ECG that inform surgeon immediately and diathermy should be discontinued immediately. If cautery causes asystole, you place magnet over the control unit and change from inhibitor to the fixed mode so that at least some rhythm will start, and maybe you need to resuscitate those patients, right? And be alert of R1T phenomena with the cautery is possible. Post-operatively, you should avoid severing. You should always check the device again and reprogram if necessary. So device checking is very, very important, and as early as possible after the surgery, it should be done. Special situations like PET-CT is ideally contraindicated in these patients. MRI is contraindicated, but however, the MRI compatible devices are now available. PNS and TENS should be very less to be used, or it should be good distance from the pacemaker. Lithotripsy can be used, but at least it should be kept 6 inches away from the pacemaker. Defibrillation can cause, let's say, if you have to use external defibrillators because of arrhythmia and the pacemaker is not working or ICD is not working, then this defibrillation can cause permanent damage to the pulse generator, and it needs to be readjusted accordingly. Radiation therapy can also reprogram inappropriately, so it should be used with very caution. If you have to take up these patients for emergency surgery, let's say if the patient has come with acute abdomen or some polytrauma, and you need to undergo surgery and you don't have a time to check what is happening. So basic scan about what devices, keep everything, emergency things are ready. Keep your all CPR related external pacing or temporary transvenous pacing or transcutaneous pacing modes are available, and defibrillators should be available, and device function should be checked as soon as feasible post-operatively. Something about the magnet. Magnet is a device which you can secure over the pacemaker implant site, and usually it leads into the asynchronous mode, but it does not necessarily guarantee asynchronous mode always, and response can vary also according to the manufacturer models. So that is very, very important that you check magnet response pre-operatively to avoid surprises on table, and it should be done ideally in presence of cardiologist or the device company person, right? There are certain things for the patients with ICDs. It is very, very important that you defibrillator mode should be off when you're taking this patient for the surgery, and you need to, if any arrhythmia happens, you need to manage them according to the guidelines. And don't expect that ICDs or the defibrillator machine which has been placed inside the body will solve the patient, because you have done the defibrillator mode off, right? And it should be magnet should be there during the entire duration of surgery. And as I told you, any subsequent arrhythmias needs to be followed by ACLS or standard protocol. And shock delivery cannot be inhibited or programmed ICDs, right? So in conclusion, this is a beautiful side. If your patient is having some cardiac implantable devices, then you whether it is a pacemaker or ICD, you find out. If there is a pacemaker and you thinking that the procedure or the surgery which they are undergoing will have some electromagnetic interference. If there is no electromagnetic interference, no issues, you can go ahead with the surgery. But if there is electromagnetic interference, then you have to see that whether this patient is having a pacemaker dependency or not. How do you know the pacemaker dependency? By the ECG. More than 40% of the complexes are paced, or entire complex are paced. That means the patient is this pacemaker dependency. If the patient is not a pacemaker dependency, then there is no need for reprogramming. You just keep magnet available and you can proceed with the surgery. But if the patient is pacemaker dependent, then you see that the source of electromagnetic interference, which is away from 15 centimeter, then also probably you can just keep with no reprogramming. But if the electromagnetic interference on the surgical site is very close to or less than 15 centimeter distance, then definitely you need to reprogram to the asynchronous mode. If your patient is on an implantable defibrillator and there is a electromagnetic interference which is likely to happen with the surgery, then you deactivate ICDs. And if the patient is having along with that the pacemaker function, so we follow the same thing which we are following with the pacemaker. So you look for the surgical site, which is very close to the pacemaker site, then you probably need to reprogram that, right? So with this, like if you have this finals today, heart-throbbing final, and if your heart escapes or you may have a tachycardia, don't worry, you will not be needing a pacemaker. So enjoy, and I wish and pray for the India, but whatever the team which you are supporting, support with the good throttle. Let's have a good final today. Thank you very much.
Thank you,
Thank you, sir.
Dr. Hetal. That's a fantastic. I think you have never not left even a point unanswered, and very good presentation. So, okay, there was one question in the chat box by Bhaskar sir. Bhaskar sir,
Yes,
what common types of cardiac diseases patient with ICD we come across in the practice?
ICD. So this is implantable cardiac defibrillator, right? So these patients
Yeah.
are having a, most likely they would have a some amount of coronary artery disease, and that would have led to the scar of the myocardium. And this would be the commonest people which we can get is IHD patients. So ischemic heart disease patients which had a massive MI, and those areas have become scarred, and that will generate a lot of arrhythmia to these patients. Another set of the patients is the cardiomyopathy patients. So the cardiomyopathy patients who cannot be managed, and they would have some intrinsic arrhythmia issues. So the cardiomyopathies and ischemic heart disease patients are the commonest patients who would have ICDs in place in their body. And very rarely valvular heart disease patients, especially aortic valve disease where the LV has become so dilated, then this kind of patients would have some kind of arrhythmia. So it's cardiomyopathy, especially dilated cardiomyopathy, IHD patients, and some amount of valvular heart disease. These are the commonest cardiac disease patients who would need intracardiac defibrillator.
So I think I'm working in obstetric industry. We commonly come across cases of cardiomyopathy, peripartum cardiomyopathy.
Peripartum.
I just want to know how much these implantable devices are going to be useful in them, because certain times we are left out with no option. Our drugs are not working. We need to have something to push the heart. So how much is it helpful? So just want to know this thing because I want to.
See, ICDs will work. So there are three types of devices. One is a pacemaker, which will give the rhythm. ICDs are this thing where whenever you have arrhythmia, it will shock. So rather than you have external defibrillator, you have implanted defibrillator in the body. And third devices are the CRT, that is a cardiac resynchronization therapy devices, where you have a poor LV function patients, where it will generate, it will synchronize in such a way, and it will reduce the QRS narrowing, does the QRS narrowing, and it will improve the cardiac output. Now, the setup which you are saying is a where you are having a perioperative cardiomyopathies. The commonest treatment of perioperative cardiomyopathy is the baby to be taken out. Once the baby is to be taken out, usually these patients usually settle down. So they would not be probably requiring this kind of devices, but they would be having, you probably will need some, for some time being, they would be needing some kind of inodilators or inotropes for managing them with good amount of Lasix or diuretics, I mean anything. And just you have to maintain the hemodynamics. Usually with the hormonal imbalance and the baby is out, usually this cardiomyopathies usually settle down in few days or weeks time. Yes, you need to follow them up. If this cardiac function doesn't improve, then probably depending on the ECG and depending on their conditions, and there are now good medications are available, oral medications are available, so they can be given the trial of those medications. And even if it is not improving with that, then probably the role of devices will come into the picture. So for immediate perioperative cardiomyopathy, if hemodynamics are not getting maintained with the help of inotropes or vasodilators or inodilators, then probably you can think of placing the IABP, which is intra-aortic balloon pump, for hemodynamic stability, or in a worst scenario, probably ECMO, but not the cardiac implantable devices.
Raju sir,
Thank-
you need
Yes.
anything inputs?
Yeah, actually, in the peripartum cardiomyopathies, it is very rare to have these devices on. But if it is a known patient of cardiomyopathy coming for a cesarean or something, which is not peripartum, but already a patient had a cardiomyopathy like a POCM or something, then probably there is some role for these devices. But nowadays, what is happening is not only the various devices are being used now in the heart failure patients and all, and very early into heart failure patients. So it is nowadays not very rare to see a patient with pacemaker or one of these devices coming for incidental surgeries. We are very commonly seeing, like in our center, we almost monthly 4-5 cases we do who are already on one of these devices, either on the CRT device. Day before yesterday only we did one case with a CRT device. The pacemaker is very common. Among the pacemakers also, the most common pacemaker we have is either DDD or VVI. So like Dr. Hetal said, from the X-ray itself, we will be able to make out actually whether it is a dual chamber pacing or, and history is very important. And what is the indication why they have put a pacemaker or a device? I think that is most important, because many a times it may be underlying heart failure for which they have put the device. So in that case, our fluid management and our intraoperative management using using anesthetic drugs which are not cardiac depressive are very, very important. I think in the history, like Dr. Hetal said, history is very important, why it has been inserted. Usually, if we can get the previous notes of the patient, we will be able to find out what is the reason, because the pacemaker itself could have been inserted only for a heart block, not for heart failure, which could be a senile degeneration, age-related also. But nowadays, it's very, very common to see a patient with pacemaker coming for non-cardiac surgeries.
Other thing I want to know, when these patients are come to centers other than cardiac higher centers, if it come to, is it mandatory to always to have the technician, that person to be there, or how to manage those cases?
I think better to have a pacemaker, what we call as interrogation. That is, we call these technicians pre-operatively, and they come and they find out, they interrogate the pacemaker, they have the machine, and from that they generate a report and give how dependent this pacemaker a patient is dependent on. It's better to have that report in hand before we proceed for the surgery, so that we know whether the pacemaker is functioning well or not. Sometimes what happens is pacemaker could have been inserted long back, the battery life is almost over, or the lead could have been displaced. So many of these factors can happen. So I think it's better to what we call as interrogate the pacemaker before the surgery, have that report, and be prepared as per the report what is needed. Of course, those common precautions like using a bipolar diathermy or keeping the earthpad away from the pacemaker, very close to the where they are using the diathermy, using short bursts of diathermy. All these are very, very important. Before every surgery, I tell the surgeons, please use in short bursts. Yesterday also, I made them use only bipolar cautery. I said, use bipolar cautery only, because we could not reprogram that pacemaker. So we said, okay, use only bipolar cautery. So such type of some common precautions are there, like using like already Dr. Hetal has mentioned, less energy, less frequency of using the some surgeons no, they use continuous diathermy. It's not good. They can use in short bursts, lower energy possible, and if possible using bipolar. Or now the other devices are there, like harmonic scalpel and all, which don't interfere with this one, if they are available. For these cases, we should encourage them to use these things. And especially if they are on AICD devices, then that defibrillation function has to be controlled, has to be reprogrammed. So for that, definitely we need a technician, sir. We need a technician. We need not have cardiologists in the theater, but not even that. The technician need not be in the theater. He can reprogram it. We finish the surgery and we call them back. They come and put it back on the same program as what is there on the pre-operative period. Dr. Raza?
Yeah, in fact, sir, what you're saying is absolutely right, because this main problem is seen when it comes to cauteries, the TURP with pacemakers. And it is one of the favorite questions from the examiner's point of view also. And in these are because they continuously keep using the cautery and keep on resecting. So this is where I think Dr. Hetal has already mentioned where you need to keep the, how far it should be there, the cautery unit and from the pacemaking unit. So these are the few things I think very well informed. And Dr. Hetal, is this the same thing even now holds good, that lithium batteries will last for about 8 to 20 years and dual chamber somewhere about 7 to 10 years, or now we have much better?
So now the devices become more smarter, and this device industry has also become more smarter. With more and more programmable devices, which has come up, which is helping the patient's own rhythm to work whenever it is possible, so that the device is working less. So thing is that the battery will last longer. So you have sometimes there is a mode which is called a sleep mode. So when patient is definitely, when we go to the sleep, our native heart rate goes down. So let's say if my basal heart rate is 80, if I'm going for the sleep, my heart rate would be about 60 to 72, right? So the pacemakers are coming with a smarter this thing which is having a sleep mode. So when the patient is going for the sleep or particular time of the day, the heart rate becomes very less. So the battery will last longer. But as I said, according to the guidelines by the Heart Rhythm Society, if you have a standard pacemaker, it should be integrated within last 12 months. If you have a ICD kind of device, within 6 months, and if you have a CRT kind of a devices, you should be getting integrated in last 3 months time. Uh, uh, just to add to what Raju sir has said, is that let's say you don't have a time for integration of your devices. Let's say if your patient is coming for emergency surgery and you know that this patient is having some amount of implantable devices, I think the basic of history, ECG and X-ray will tell you a lot of things. So ECG history will tell you what was the indication, or probably looking at the previous papers, you would come to know that what was the indication, when it was been done, where it was been done, which is the place, when it was last integrated. So kind of those kind of things. ECG will tell you whether this patient will be having a pacemaker dependency or not. So more than 40% of the complexes, if they are getting paced, that means this patient is a pacemaker dependent patient. And your X-ray will tell you that if you have 1 wire, 2 wire, or 3 wire, or wire with the more radiolucency, that will all tell you whether this patient is having a which devices. So let's say patient with the defibrillator kind of devices, very prone for arrhythmia. Patients with the 3 wires, that means these patients are having a resynchronizing therapy, and these patients are having definitely poor LV or ejection fraction less than 25-30%. So this will all tell you a lot of things. From ECG, X-ray history, will come to know a lot of things, and accordingly then you can think about and start managing these patients. I have a short video of a magnet. If you can allow me, I can just show you what magnets are actually doing, if there is a permission from the moderators.
Yeah, please.
Yeah, I'll just show you that. So this is a patient who's having a heart rate of around 70, 72. Let me just stop the 1 minute. I'll just stop the. Let me put it on a mute mode. So this was the patient who had an intrinsic rhythm of about 70, but having a very high kind of block. So we need to do a pacemaker, and we set the pacemaker at a 60. Now this is a magnet which we have placed. See the medical device guy is only interrogating, and see, you can see this in even he has to handle the magnet. So when we have put the magnet on place, the own intrinsic rhythm has started coming. See, this was the patient's intrinsic rhythm with the heart rate of about 100. Right, but he's got a very vague, very varied rhythm and very high block, and that's why this patient was needed a pacemaker. So this was the magnet we've been placed. Machine has gone on asynchronous mode, and patient is having own rhythm of about 100 rates per minute. Right, so right, and now if you take the this magnet out, and now machine is started working, and if you can see the normal QRS complex and P wave, and slowly you can see the heart rate has come down to the 60, which has been set to the patient, right? But this kind of interrogation is very, very important before surgery, because so that you come to know that where you need to place this magnet, and what this magnet is going to do with the pacemaker machine. So this kind of magnet should be ideally available. Any kind of magnet is available. It's not required this kind of, but any sort of magnet has to be there to make them in asynchronous mode. But yes, if the patient is having a pacemaker dependency, then it will be more dangerous to defunk these magnets with the machines with this magnet, because patient doesn't have much of the intrinsic activity. So ideally, the interrogation and some amount of time sparing with this kind of patients preoperatively will help you a lot of things. What exactly you need to have in your preoperative preparations if these devices are not functioning, right? So that's very important. Defibrillator function has to be put off, and you need to do any sort of arrhythmias, you have to deal with standard ACC/HA guidelines.
Am I right in saying that it should be handled only by the technician, the magnet, right?
No. So if you have a time, and if you can call that a company person, let he be available, and you do it, so that you get also confidence, right? But
can I
what
share
happens?
A point, please?
Pardon?
Yeah, you finish, sir, please.
Yeah. So, but if this magnet sometimes behave erratically, they can cause a lot of problem with the devices. So, if your company person is around, he can reprogram the device immediately, right? So, all this will be known to you beforehand if you have an interrogation beforehand. If you don't have interrogation beforehand, usually the magnet will put in a asynchronous mode. That's almost 60-70%. But I mean, it's better to have it, and you do it so that at least you get the confidence of it in front of the technicians or the person who can reprogram it immediately.
Can I share a point, please?
Dr. Kumar?
Yeah.
Yes.
Can I share a point, please, here?
Yes.
Yes,
I'm
sir.
Dr. Giridhar. Yeah. Last
please.
month I did a case on ICD. So the newer interrogation person came and told the device was placed for 5 years, and the total amount of arrhythmias occurred in the 5 years was 33. And how much interrogation has been done by the machine? And the last year it was whether it is frequent or increasing. So this gives an idea about the risk of the patients also, and how far we can confidently manage the case with the recent interrogation reports. They have given a report of about 1.5 pages. So last 5 years, how the patient behaved, and also the amount of intervention done by the device also helps in the efficacy of the battery, even though it is more than 10 or 12 years. So the newer reports of interrogation is so advanced, so it gives a very good idea about managing the case without any hindrance or any jitteriness. That is one thing I want to say.
Thank you. Dr. Kumar?
Somebody is asking anything. Yeah, thank you, sir. Dr. Kittal, it is an excellent lecture.
Thank you.
Targeting the audience, you did a fantastic job. Thank you very much.
Thanks a lot, sir.
A few comments. Number one is about pacemaker dysfunction during the surgery or immediate pre-surgery. Then there will be a patient will go for an asystole. That time you should be ready with tackling the patient with either transcutaneous pacing or transvenous pacing.
Yes.
So transcutaneous is well available with all our defib machines nowadays. So transcutaneous, you can straight away go ahead with it, do that transcutaneous pacing. That is number one about pacemaker dysfunction or asystole during the surgery in patients with the PPA. Number two, there may be possibility for R&T phenomena. So during surgery, when we are going ahead with pacemaker on function or in asystole mode, there may be fighting with own rhythm with the pacemaker. That in such situation, R&T can occur and produce VTAC, ventricular tachycardia and fibrillation. So in that situation, we have to go ahead with external defibrillation. That external defibrillation paddle should be at least 10 to 15 centimeter away from the pulse generator, pacemaker generator. So that point should be because routinely they will put it directly over that generator, and generator malfunction will happen. Then we'll land up in emergency situation for going for the either entire system changing, or you have to go with temporary solutions. So that is about R&T and external defibrillation. Number three, about programming and reprogramming. Programming, as you said, it has to be done in the pre-op status. But in PPA or all other CRT devices, you can do that. But in case of AACD, the patient is having high fibrillation threshold or frequent VTs or VF are coming. In that situation, we cannot do it in the pre-op situation. Better to do it on table. Proceed for AACD deprogramming or programming to deactivate the mode, and then proceed for surgery. If there is any VTAC, VF during the surgery, we can do the external defibrillation. So except AACD, other things can be done in the pre-op, but AACD better to do it on table. About the emergency situation, that is well said. No other choice. You have to go ahead with the surgery. You cannot ask for all the options available for the elective patients. So better to avoid the electromagnetic interference as away from that generator and lead. And as sir was telling, short burst and low energy are better options. These are the things has to be done in emergency situation. In emergency also, external defibrillation plus transcutaneous spacing will definitely take care of your pre-op management. Thank you, sir.
Thanks for the comment.
As actually, what Dr. Bhaskar was saying, it's very easy to get a interrogation and the reprogramming in units where the cardiology is there, and like in pure obstetric units where I think Dr. Bhaskar is working, is very difficult to get the technician, because we should know which make and all these things. I fully agree with you that those are more difficult circumstances. It is very easy to reprogram this or interrogate this in cardiac units, where always those technicians will be available or they come on call. But for obstetric units, which don't have a supporting cardiac unit, is very, very difficult to get those technicians also.
Yes, sir. Very, very practical problem, sir.
Dr. Hetal, can you throw some light on the pacemaker syndrome? Again, very commonly asked.
Yeah.
Do we see now or we don't see anymore?
No, not that frequently. We can see that pacemaker syndrome is a condition where when you have put the patient on a pacemaker and they usually don't be very happy with the therapy, and the heart is not happy with therapy, and there is a progressive worsening of the symptoms, particularly congestive heart failure and all those things which happens. But this was happening more frequently with the single chamber pacemaker, which is like a ventricular pacing which was happening to the patients, right? And it is nowadays with the newer pacing devices, and most of the time they put synchronous pacing, they put dual chamber pacemaking. This kind of thing, which is very commonly happening with the patients who are having a single chamber pacemaker, and they have asynchronous pacemakers. But nowadays with the newer devices, and there's a lot of development and research which is going on in these devices companies also, and they do come up with a very, very good mode. So as Dr. Pieshan sir said that it's mostly the DTD or VVI which has been placed. So DTD is very common. So with the dual chamber pacemaker, as I mentioned in my lecture also, that the normal atrial contraction followed by the ventricular contraction happens, and that will increase your cardiac output by almost 15 to 20%. And it mimics like a normal cardiac output. So with the newer devices, it is very rare to find the pacemaker syndrome nowadays. But yes, people who has an older age generation, pacemakers or single chamber pacemaker, asynchronous pacemaker, they do have something. But with newer devices, very, very less frequent now.
Correct. So I think pacemaker Twiddler syndrome also is nowadays seen.
Pacemaker?
Where
Sorry?
Twiddler, TWIDDLER first phase, Twiddler syndrome.
Okay.
Basically, what happens is there's a permanent damage to the pacemaker, which results in manipulation of the pulse generator, which within its skin pocket. So that is what it says. Again, as you say, though it's rare, but it's, I think, seen quite often. Twiddler syndrome, or pacemaker Twiddler syndrome.
And sometimes it may happen that these patients would, because it has been placed usually in the subclavicular area, sometimes this pacing will induce the brachial plexus stimulation also, and that might cause a lot of twitching of the hands also. That is also possible. Twiddler syndrome, I have never seen, to be very honest with you, in my practice till now. Yeah, pacemaker syndrome we have seen, but Twiddler syndrome is very rare to find now.
Any other questions, sir? Anybody? Bhaskar, sir? You can...
Yeah. If there are no,
with that, we hand over to
Bhaskar. So thank you, sir. Thank you. Actually, it's a very nice session, both the session. I should actually, we are commonly coming across a patient coming with all these implantable devices. Nowadays, it's very frequently we are coming, even the government setup, we have seen, we are seeing cases. And last month, myself and Giri handled cases, same thing like this. So I think the next generation has to be well versed with what's new things that are going, especially in cardiac. What we are told, these are things I dreamed when I was doing my PG 20 years back. Now everything is coming into the field. So I really thank you for both the speaker for a very nutshell program, giving everything in a nutshell. Thank you, sir. Thank you very much for both the speaker as well as both the moderators sharing their experience. And Kumar sir, as usual, the backbone for our program. he throws, it's his area. And Kripa sir, I want to thank Kripa sir and the absence of Dr. Selvakumar and Dr. Amuda madam has nicely guided the program. And with this, I would like to end this semi-program, and we would like to go with the city branch report of Vellore city branch to be presented by Dr. Prabhagar, the secretary. Dr. Prabhagar.
Can we leave Dr. Bhaskar?
Yes, sir.
Yeah.
Yes, sir.
Thanks for giving me this opportunity. And let's hope for the Team India.
Yes, sir.
Thank you.
Thank you for the opportunity, sir. Thank you.
Thank you, sir. VNS Raju, sir. Selvakumar, sir. Bhaskar, sir. Udarani, sir. Gupti, madam. Thank you so much.
Yeah.
Thank you.
Thanks.
Thank you also. Thank you.
Prabha?
Yeah, can I
Prabha, you
start
can go
now?
ahead. Yeah, please.
So, respected office bearers, distinguished moderators and speakers, if you are here, senior anesthesia members of ISA, I'm happy to report a few activities that happened in Vellore ISA this year, and about 1 or 2 activities that are going to happen this year. So, Vellore has a mixture of anesthetists from various types of working atmospheres, starting from the prestigious Christian Medical College. Now we have the government Vellore Medical College. We have anesthetists working in many corporate hospitals who have DNB in anesthesia. We have anesthesia people working in district hospitals, and we have freelance anesthesiologists. So Vellore ISA will now aim to integrate all these anesthesiologists under one banner so that we can make this more of a progressive outlook. So in the months of August and September, there were 2 anesthesia meets conducted by the freelance anesthesiologists of Vellore. Some 25 to 30 anesthesiologists attended these two meets. And in the month of December, we are planning to have an anesthesia quiz for the postgraduates in anesthesiology. So we decided that this anesthesia quiz will be hosted by Vellore Medical College, Viluppuram Medical College and Tiruvannam Medical College in turns. So this year, this quiz will be hosted by Vellore Medical College. And once the program is finalized, program invitation will be given to all the anesthesiologists across the state and in the country also. That's all we have for this year. Thank you for giving me this opportunity, Bhaskar. Over to you.
Thank you, Prabha. I personally congratulate Prabha for taking the post and as well as is taking steps to make Vellore to higher place. So, and other thing, I want to thank the Vellore ISA members for actively participating in the online voting. Their contribution is all small units performed well, especially Hosur, Chidambaram, Vellore. Everybody, they were actively participating in the online voting, which made our state perform very well and get very much notified in the all India level. So I would like to thank him and my best wishes to him. Thank you. And with this, I would like to hand over the vote of thanks to our Honorary Treasurer, Dr. Giridharan.
So good afternoon,
Giri.
all. Yeah.
Please.
Good afternoon, all. On behalf of the ISA Tamil Nadu office bearers, I would like to thank the Vellore branch for co-hosting with the Tamil Nadu ISA for this monthly CME meet. I thank Dr. Gomati, President ISA, and Dr. Prabhakar, Secretary ISA Vellore branch for coordinating. I also thank the moderators, Dr. PSN Raju and Dr. Azam, for moderating the session in a great way and giving the inputs of two important topics of tetralogy of Fallow and intracardiac device management. I also congratulate and thank the speakers for making this topic an interesting one and an informative one. Dr. Satish Kumar from Cardiothoracic Unit of CMC Vellore and Dr. Hetal Kumar from Narayana Hridalaya, Ahmedabad. I also thank the audiovisual session of for making this program. I thank the God Almighty for making this program a grand success. Thank you all. Long live ISA.
Thank you, everyone. Thank you, and we wish good luck to India, Team India.
and hope to meet at Gurugram.
We'll meet.